Hello, everyone. I'm Dr. Rusell Barkley, and I'm a clinical professor of psychiatry at the Virginia Commonwealth University Medical School here in Richmond, Virginia. Today, I'd like to speak with you about the comorbidity or overlap of ADHD with autism spectrum disorder. And I'm going to talk about the implications of this for understanding these disorders, which should inform your diagnosis of them, as well as talk about the management issues that are raised by this comorbidity. I do want to begin by saying that I'm delighted to have been invited to speak to you on this topic today, and I do hope that you will find this presentation to be informative. ADHD has an extremely long history, going back more than 250 years to its first description in the medical literature around 1770 to 75 in Germany, in the first medical textbook published in Germany, written by Melchior Adam Weichert. Autism spectrum disorder, as you know, was discovered much later than ADHD. So there's quite a difference in the history of these disorders. I won't have much more to say about that, but I did want you to know about the difference in how long these disorders have been known to medical literature and to psychiatry. And as you can see in the lower right-hand screen here, ADHD is an extraordinarily well-researched disorder. As of 4 years ago, just a quick search on Google Scholar showed that there were more than 300,000 references to ADHD, now more than 350,000, I'm sure, in the research literature. So there is a very strong literature on the nature of this disorder. You know that our diagnosis of ADHD and of autism spectrum disorder, ASD, is guided by the criteria in DSM-5. Let's take a quick look at these criteria and see how they might differ, as this will help us in establishing which disorder is present and whether or not they are comorbid. ADHD is a neurodevelopmental disorder. So is ASD. ADHD is recognized by having a significant number of symptoms of inattention, as well as of hyperactive and impulsive behavior. And individuals have to have at least 6 out of 9 symptoms on either of those symptom lists in order to receive a diagnosis. In the case of adults, that has dropped slightly to 5 symptoms on either list. In the case of ASD, it's quite different in diagnosis. There must be persistent deficits in social communication and interaction, and a considerable list of those problems is presented in DSM-5, and all of them must be present. In addition, the individual must have at least 2 out of 4 of the symptoms listed under the category of restricted, repetitive patterns of behavior, interests, or actions. Both disorders require that the level of symptoms be developmentally inappropriate. This is certainly much more important for ADHD, which places along the lower end of a continuum of normal behavior in typical children, with the disorder being partly identified by how extreme and significant its symptoms of inattention and impulsive hyperactive behavior happens to be. And while ASD certainly requires that symptoms be developmentally inappropriate, it is far less indicated that ASD is that difficult to differentiate from typical child behavior. So there's a considerable difference here in that ADHD is more of a quantitative difference in normal functioning or from normal functioning, whereas ASD presents even more qualitative differences in addition to quantitative ones between people with ASD and those with typical behavior. Now, ADHD requires that the symptoms have lasted at least 6 months to ensure that the individual isn't simply going through some developmental stage, such as the terrible 2s and 3s, when hyperactive or inattentive behavior might be more common even in typical children. This is far, far less the case in the early development of children with ASD, where the problems with language, social communication, restrictive and repetitive behavior patterns, and possibly even intellectual delay or disability are far more striking in many, though by no means all, of those children. ADHD, because it is a quantitative difference, is identified by being persistent and pervasive across several different situations. This is to make sure that it's not simply a situationally inappropriate problem, such as difficulties getting ready for bed in the evenings, for instance. On the other hand, ASD is a much more pervasive disorder of development, and there is little need to specify that the symptoms have to occur in more than two places, because they invariably do. Now, that said, both disorders are diagnosed with the requirement that there be impairment in major life activities that result from these symptoms. So the criteria of impairment is very important in identifying where a disorder begins and where typical behavior may leave off. Now, in ADHD, the requirement is that the symptoms have developed in childhood or adolescence, sometime before or by 12 years of age. However, I will tell you that the recall of onset of symptoms in ADHD is very unreliable, and therefore no one should place a great deal of emphasis on age 12, so long as the symptoms have developed sometime during the developmental period of human development, say up to ages 24 or younger, then it is a valid case of ADHD if all the other criteria are met. In the case of ASD, the symptom onset is usually even earlier than that in ADHD, often by several years or more, and frequently being identified during the preschool years. In contrast, about 50% of cases of ADHD in community surveys were identified after the age of 12. Yet another reason for us to ignore that requirement for diagnosis. And that is far less true for children with ASD, where many of them were identified prior to 4 or 6 years of age, and some even earlier than that. Now, ADHD and ASD both require for diagnosis that one exclude other disorders that might better explain the presentation of those symptoms. In the case of ADHD, that might be bipolar disorder or disruptive mood dysregulation disorder. Whereas in the case of ASD, we're looking at intellectual disability, such as might be seen in Down syndrome, severe language disorder, or pragmatic language disorder as seen in the syntactical problems of the new language disorder, just specified in DSM-5, not to mention, of course, distinction from childhood schizophrenia. So the differential diagnosis of the two disorders is quite different in terms of what other disorders might mimic these kinds of symptom presentations. Now, ADHD says that there are three different presentations of symptoms. Again, don't put too much stock into these presentations. They don't signal any qualitative differences. They're simply there so that clinicians can indicate which dimension of symptoms might be more or less prominent at the time of the evaluation. But they certainly don't predict that that's going to be the ongoing presentation for the rest of the individual's development, much less their life. And there are no such distinctions made in ASD, perhaps with the exception of ruling in or out intellectual disability or ASD with or without a serious language disorder. But that's really not so much subtyping as simply specifying the current nature of the delays characteristic of ASD. Now, to better understand the symptoms of ADHD, this will help us, I think, to better understand its differences from ASD. ADHD is a neurodevelopmental disorder that is characterized by delays in the development of two neuropsychological traits, The first one to emerge in development is that of disinhibition, a problem with executive, willful inhibition or self-restraint. And this gives rise to both the hyperactive symptoms of motor restlessness and hyperactivity, so characteristic of many preschool children with ADHD. But that will decline in time, such that by adulthood, the hyperactivity is no longer a useful diagnostic set of symptoms in differentiating adult ADHD from typical people or other disorders. Now, ADHD's problem with inhibition is also characterized by verbal disinhibition, such as excessive talking, interrupting of others, or intruding on others. Neither of these symptoms is thought to be traditionally characteristic of ASD, unless, of course, the two disorders are comorbid. Now, in addition, ADHD shows a problem with cognitive impulsiveness. The individual is acting very quickly without thinking, making decisions about their actions almost as if they were automatically determined. The person is not stopping to think through the longer term implications or consequences of their actions. And we refer to this as sort of a cognitive impulsivity, acting very quickly on ideas that come to mind. This is not characteristic of ASD. ADHD children and adults also have a motivational impulsivity in that they routinely opt for small, short-term consequences over working for larger, later, and more socially important consequences. So there is a clear high time preference in people with ADHD for pursuing immediate rewards. And while this might be to some extent true of some ASD children, particularly if they have comorbid ADHD, it is not a classic symptom of the disorder. And the individual's preference for immediate over delayed consequences probably has more to do with any presence of coexisting intellectual disability rather than a problem with executive inhibition and impulsivity. ADHD children have a lot of trouble with emotional inhibition, emotional self-regulation. Their emotions are shown very quickly when provoked. But those emotions are short duration, often situation specific, usually provoked, and are understandable. They're rational. They're just a little immature in that the child, for their age, should be showing more self-control of their emotion than they happen to do. So there's a problem with the executive top-down regulation of typical emotions, making the individual appear to be immature. In ASD, some of the emotions, particularly panic reactions, meltdowns, or what we think of as limbic storms that can be characterized by both anxiety and panic as well as by aggression, what we see instead is a qualitatively different pattern of emotional responding that is not typical of other children of the same chronological age, and indeed may be extreme in the sense that the individual becomes irrational and, at least for a while, incapable of reasoning through their emotional expression. So some of the emotions seen in ASD are quite extreme, easily provoked, sometimes by irrational events, and can be longer duration and more difficult to recover from. So there's a lot more going on in ASD than simply a problem with self-regulation of emotion. Now, as I've said, the hyperactivity seen in ADHD declines markedly with age, whereas ASD is not characterized by hyperactivity per se, even though in certain times and places such children might be hyperactive. In other times and places, they can be incredibly hypoactive, slow-moving, and passive and even withdrawn. Now, the inattention dimension in ADHD is characterized by problems with more than just concentration or persistence over time. We refer to these difficulties as executive attention problems, or better yet, symptoms of impaired executive functioning. The executive functions of the brain are what we use for self-regulation, and ADHD is clearly a pervasive disorder across most or all executive functions, and that is its primary problem. So what we call inattention is really a problem with executive functioning and self-regulation. Now, the problem with attention is a rather specific one. There are at least 5 or 6 kinds of attention that are mediated through the human brain, and ADHD doesn't interfere with all of them. It interferes with one in particular that makes it quite unique, and that is attention to the future. People with ADHD have trouble persisting over time toward goals, tasks, assignments, and deadlines. Along the way, they also have difficulties with resisting responding to distracting events, what are goal irrelevant events. And when distracted, the individual with ADHD will find it very difficult to go back and re-engage the incompleted task. And that's because ADHD is producing a primary and substantial problem with working memory. Working memory is one of the 7 executive functions, and it refers to remembering so as to do. The individual is actively holding consciously in mind their goal, the steps to the goal, and the progress they've made so far in getting to that goal. Working memory is what you start to lose at my age, where what happens is that the environment becomes more compelling when we go into a situation, and our mental representations about working memory and what we're doing are becoming weaker and less able to govern our behavior over time. And that's classic of people with ADHD as well. So there's a problem not just with persistence over time toward the future and resisting distractions, but one of working memory difficulties, that is, remembering so as to do. People with ADHD also are impaired in their self-monitoring, being less aware of what they're doing and of their symptoms and impairments than are other people typically of their age. Now, some of these difficulties are certainly seen in ASD, but they are not the primary symptoms. Where we see them, they are secondary to the difficulties with language, intelligence, social communication, and with restrictive and repetitive patterns of behavior and activities. So ASD is not a primary problem with executive functioning, but can lead to some secondary deficits in some of these executive functions, particularly the verbal working memory system compared to the nonverbal or visual spatial working memory system. ADHD produces much more difficulties with nonverbal than verbal working memory, although it disrupts both of those working memory systems. Whereas ASD is more likely to have problems with verbal working memory, most likely due secondarily to their problems with language development. And since self-speech and working memory are based upon language, any primary impairment or bizarreness or disruption in language development is going to carry over into the mind's voice and the verbal working memory system and create secondary problems in that system. This is far less likely to occur in the visual working memory system, the visual spatial system in ASD, where we sometimes find that people with ASD have better developed visual working memory systems, often having incredible memories for things that they have seen and are able to retain and hold in mind. So watch for these differences. And again, the same is true with self-awareness and self-monitoring. That in ASD could easily be due to the kind of inattention that ASD is associated with, which I'll speak about shortly, rather than again being the result of a primary problem with executive functioning and specifically self-monitoring and self-awareness. Now, when we look at ADHD, as I've said before, ADHD is a problem with executive functioning. So technically, it really is EFDD because it's interfering, as I've already described, with all 7 of the executive systems, from self-awareness to inhibition. By the way, inhibition is not a classic symptom of ASD, unless, of course, it's comorbid with ADHD. And in fact, disinhibition is one of the classic symptoms for differentiating these two disorders. ASD children are not chronically disinhibited. Working memory, both verbal and nonverbal, are impaired in ADHD. And as I've said, it's more likely to be verbal working memory in ASD children. ADHD disrupts emotion regulation, as we've discussed. And to some extent, ASD does as well. But again, the symptoms of emotional problems in ASD are qualitatively different and are not characterized as simply immaturity as much as there are qualitative differences in complete dysregulation of certain emotions, such as anxiety, panic, fearfulness, and to some extent, even aggression. ADHD shows a problem with self-motivation and with planning and problem solving. And while ASD can interfere with these as well, the point I made previously still applies. The deficits in executive functioning are probably secondary to the major widespread problems that ASD is causing in language, social communication, intellectual development in most cases, and restricted and repetitive interests. Now, there's a new attention disorder that's been discovered over the past 20 years, and it's misdiagnosed as ADHD, but its real name in the research literature is called sluggish cognitive tempo. Now, I don't like the term, and it's going to be changed by researchers presently, probably by the end of this year, which is 2021, to something less offensive and more accurate in describing the problems, because children with SCT really don't manifest sluggish cognitive timing or processing. But instead, such children are characterized, as you see here, by staring, daydreaming, a decoupling of attention from the external world and ongoing events, and instead an internal preoccupation, often with daydreaming, mind wandering, or other mental activities, so that the individual is unavailable for coupling with and processing the external environment. ADHD, on the other hand, is a problem, as we've said, with hyperactivity, impulsivity and risk-taking, immature emotion, and, as I've said, difficulties with persistence over time toward goals and tasks. So the individual with ADHD is overly coupled to the now, to the moment, and is easily distracted by momentary events. And they're not being governed by mental representations about time, goals, the future, and goal-directed action, things that need to get done, what we would call intentional behavior. Whereas SCT is the opposite, an uncoupling of attention from the external environment. Now, I think you can see why we're discovering that while SCT can overlap with ADHD, as it does in about half of all cases of each, SCT is much more commonly seen in ASD, this uncoupled pattern of attention from the external environment, characterized more by daydreaming, staring, and mental preoccupation with mental content. So we're finding that over 60 to 70% of children with ASD have high levels of SCT symptoms of inattention, whereas we find that about 50% or fewer of ASD children have ADHD. And my feeling is that some of that is probably misdiagnosis, since most clinicians are not aware of SCT. They're going to refer to the inattention problems seen in SCT as ADHD inattentive presentation. And that could be applied to children with ASD as well in order to characterize this SCT-like staring, daydreaming, and inwardly preoccupied attention. So once we get this all clarified and measured more properly in studies of ASD children, I would expect that the rate of comorbidity of ADHD might go down somewhat from what we currently know it to be, whereas it would be replaced instead by comorbidity with SCT, or whatever the new name is that it's going to be given later this year. So bear in mind then that there are two attention problems, not just one, and that it is more likely SCT that coexists with autism spectrum disorders than ADHD, but both of them can do so. Just for your own reference, you can see here the classic symptoms of SCT. And as you look down them, you can see that many ASD children would qualify as showing several or more of these symptoms. By the way, the symptoms in yellow should be excluded in diagnosing ADHD and SCT because they're common in both disorders and not very helpful for differential diagnosis. Now let's continue and look at the fact that ADHD varies markedly as a function of context and situational parameters. In some cases, ADHD symptoms may not be apparent at all, such as when a child is working one-on-one with a grandparent or playing a game with them, or when a child is playing video games. On the other hand, ADHD may be much more severe in group situations that involve work, such as classrooms, or where there is infrequent feedback for getting that work done. What distinguishes the situations on the right, where ADHD is worse than those on the left, is the ones on the right require much more self-regulation and executive functioning. We see ASD fluctuating far less across these kinds of situations and contexts than is ADHD. Another difference between the two disorders is their prevalence. ADHD is a far more prevalent disorder in children, being about 2 to 5% if we go back and use the earlier DSM criteria for ADHD before we invented inattentive ADHD presentation, and has risen up to about 7 to 8% of children in the United States now qualifying for one of those three presentations. That is markedly higher than the 1% prevalence seen for ASD children. ADHD also shows a decline with age such that there are fewer adults who qualify than in childhood. We don't see that kind of decline or recovery from disorder to anywhere near that extent in ASD children. There are also sex differences among other demographic differences in ADHD. For instance, in ADHD children, it occurs 3 times more often in males than in females. But that sex ratio declines by adulthood, where it is 1.5 males to every female. We see no such changes in ASD, where it's about 4 males for every female diagnosed with the disorder. And the disorder is highly persistent over time. So there's very little alteration in the gender differences in the rate of disorder seen in ASD, as I have noted here. Now, when we look at persistence into adulthood, as I've said, ADHD is very persistent over the first 10 years following diagnosis and follow-up into adolescence, being about 70 to 80% or more. About 5%, at most 10% of children may recover from ADHD by late adolescence. Another 15% have a milder version of the disorder, perhaps not quite severe enough to get the diagnosis, but still highly symptomatic and probably impaired. By the time we get to young adulthood, we see that now we're seeing about 65% or so of ADHD individuals have very high levels of symptoms, even if they don't qualify for a DSM diagnosis, and most of them are functionally impaired. but about half of them will meet the DSM criteria for their disorder. About 14% or more have recovered from their disorder by their late 20s to early 30s, and we see that the remaining group are what we would call subsyndromal. Again, high levels of symptoms, some impairment, even if they don't meet all criteria in the DSM. You see, part of that's a problem with the DSM. Children can outgrow the DSM criteria, even though they're not outgrowing their developmental disability. Whereas with ASD, we see high rates of persistence from childhood to adulthood, with far less than 5% of children diagnosed with ASD recovering from their disorder. Indeed, there's almost no recovery, with a few exceptions. On the other hand, children who may not qualify for ASD by adulthood often do qualify for anxiety disorders, panic attacks, obsessive compulsive disorder, and to some extent, schizophrenia. The impairments we see in ADHD are similar but less extreme to those we see in ASD. ADHD children have early mild delays in motor coordination, in the executive aspects of speech, the ability to organize language to accomplish a goal, perhaps to some extent with some dyspraxic speech because of the motor abnormalities ADHD may be creating, and some delay in independence or adaptive skills, but usually no serious delay in intellectual development. On average, research studies show that children with ADHD have only about a 7-point difference in their intellectual development from normal compared to typical children, whereas ASD children often have markedly more serious delays across these domains of development, many having awkward, bizarre, and unusual motor functioning, gait, stance, posture, along with repetitive, restricted, and stereotyped behaviors and actions. There may be little or no speech, or what speech develops may actually be rather impaired and bizarre, although some children do have ASD with only mild or even typical language delays. And then, of course, ASD children, depending upon the severity of their language and intellectual disability, are going to show marked impairments in adaptive functioning, such as self-care, independence, and generally handling responsibilities. Both disorders cause significant distress in their families, and often the levels of distress, by the way, are very similar between the two. ADHD, because of its lack of self-regulation, places a great burden on parents, but then so do the symptoms of ASD. ADHD children, when they get to school, have higher rates of learning disorders, often begin to fall behind other children of their age to some extent, such by the end of elementary school they might be up to a standard deviation or more behind in their academic achievements, skills, and knowledge. And we also see that because of their disruptive behavior, they may have more problems with school adjustment and behavior and school discipline. ASD children, again, depending upon level of intelligence and language impairment, also have difficulties with academic achievement, but these are often far, far greater than what we would see in ADHD children. And the same is certainly true with peer relationship problems, where ADHD children are more disruptive, more active, more impulsive and emotional. But they want friends, they seek out friendships with other children, but are often rejected because of their emotional behavior or because of their immaturity. They're not rejected because of their intellectual disability or their language impairment or their complete disinterest in associating with other children, which, as you know, can be characteristic of ASD. And of course, there are differences in comorbidity for other psychiatric disorders, particularly for conduct disorder, antisocial personality disorder, substance use disorders that go with those two, and so on. And of course, anxiety disorders are far more common in ASD children than ADHD children. Antisocial behavior is common in a substantial minority of ADHD children, and that is not the case for children with ASD. Unlike ASD children, who may be somewhat prone to accidental injury, ADHD children are 2 to 3 times more likely to experience repeated accidental injuries of all types and are twice as likely to die from those injuries by age 10 than our typical children. And while ASD children have somewhat higher rates of early mortality due to their wandering and, of course, their greater risk for drowning and for pedestrian auto accidents, it's nowhere near the increase that we see in accidental injuries that is so characteristic of ADHD children. Health risks are associated with both disorders, but specifically for ADHD children, 40% have insomnia and disrupted sleep. There's a genetic risk for migraine headaches. There's also an increased risk for obesity and for dental problems. Some of these can be seen in ASD children as well. As we continue into adulthood, and ADHD children enter adolescence and progress on to adulthood, we see additional problems with substance use, risky sexual behavior, early pregnancy, high risk or higher risk for suicide than we had seen previously, and of course driving problems, particularly characterized by speeding with a motor vehicle and 2 to 3 times more crashes, as well as being cited for driving under the influence. By the time they reach adulthood and move into occupational functioning, their immaturity and executive difficulties with self-regulation are causing problems with occupational adjustment. But many will eventually leave home, if not a little later than typical adolescents or emerging adults, and many will find gainful employment. As you well know, both of those are far less likely to characterize children growing up with a diagnosis of ASD. And by adulthood, both disorders show poorer health and a high risk for obesity, and because of that, and their poor eating habits, a higher risk for coronary heart disease. But this is also affected in ADHD by their greater likelihood of alcohol consumption, cigarette smoking, use of marijuana, and to some extent use of cocaine. And if they develop conduct disorder, the risks are even higher for them developing not only those substance use disorders, but coronary heart disease and probably cancer later in life. We don't see those kinds of risks in ASD children linking up with conduct disorder, substance use disorders, and so on. And of course, when ADHD children eventually get into intimate relationships, perhaps cohabiting or marrying others, we find that their self-regulation difficulties and immaturity poses problems for their marriages or intimate relations, and that ADHD predicts an increase in intimate partner violence. ASD children, on the other hand, are far, far less likely to enter into intimate relations, cohabiting with others, much less marriage and child rearing, where ADHD, we see some mild but significant impairments in parenting due to lack of monitoring and attending to children. And as you know, in ASD children, by the time they're adults, if they have children at all, their parenting may be seriously affected. So I hope you see that the differences exist in the kinds of impairment both disorders cause. And where both disorders are present, it magnifies those impairments to a great extent. How much is it that is the comorbidity of these two disorders? Well, about 20 to 25% of ADHD children may qualify for ASD, but often placing toward the higher end of functioning, and often with ADHD being the first disorder to be diagnosed, and ASD coming years later after it has been sorted out how much of the child's impairments relate to each disorder. On the other hand, if we study children diagnosed with ASD, the diagnosis of ASD occurs much, much earlier. The diagnosis of ADHD might be added years later once the ASD has been sorted out. And the level of comorbidity can be up to 50% or more of ASD children having ADHD. So although there is comorbidity going in both directions between the disorders, it's much more likely that it's from ASD over to ADHD than vice versa. Not quite a one-way comorbidity, but certainly a one-way bias in the comorbidity. And while oppositional disorder can occur in both disorders, it is much more likely to occur in ADHD, occurring in 2/3 or more of ADHD children, and often being a sign of eventual risk for conduct disorder, which is not as likely to be seen in ASD. Anxiety disorders occur in both, but as I've said, much more in ASD. Major depression becomes increasingly likely in people with ADHD upon reaching adulthood. And while that's true of ASD children, it certainly may have much more to do with the problems with emotional control in ASD and the difficulties with social rejection. ADHD shows a high risk for substance use disorders, a high risk or higher than typical risk for bipolar disorder, being about 6 to 10% on average of ADHD cases showing bipolar. The reverse comorbidity is remarkable. Children with bipolar disorder almost invariably have ADHD as a comorbidity, and that's certainly not seen in ASD. We see problems with binge eating pathology and bulimia in ADHD in females, and we also see difficulties with, as I've said, leading to obesity. And while both disorders predispose to obesity, bulimia is not necessarily going to characterize ASD because the eating problems in ASD are not driven by the disinhibition that is specific to ADHD. And as you see, personality disorders are certainly common in ADHD children. Let me just back up here. Excuse me. It looks like my slides don't want to go backwards. Give me just a moment here, and then we'll wrap this up. Here we go. Well, these slides don't really want to behave, do they? Okay, so when we look at the etiologies of the disorders, they overlap to some extent, yet are quite different in other ways. Both of them are neurodevelopmental, meaning that the causes of the disorder lie chiefly in biology and specifically in neurological development and in genetics. And that's very true for both disorders, where there are high rates of heritability and genetic transmission of the disorders, as well as evidence for gene by environment interactions and the compounding of these sources of etiology with each other. ADHD, of course, shows a very high rate of traumatic brain injury because of risk-taking and impulsivity. In the case of ADHD, what we see is a somewhat smaller brain that is about 2 to 3 years delayed in development, with somewhat of a delay in the formation of networks of long-range nerve fibers, creating functional connectivity. But eventually those do develop. The brain does become of relatively normal size, but there continues to be striking variability in functional connectedness among certain brain regions, chiefly driven by the problem within the executive network of the brain and its development. In ASD, we often see too much brain, particularly at the gray matter level, with a lot of hyperconnectedness in little local regions, and a much more dramatic decrease or dearth of long-range connections across the brain, linking up other centers of brain functioning in a functionally connected way. So the long-range connections of nerve cells in autism are much more strikingly affected, and there's a hyper localization of brain connectivity, particularly at the cortex, that is not characteristic of ADHD children. And certainly the problems with ASD are relatively pervasive across the brain and implicate not just the language centers, but also the centers for emotion regulation and control, in addition to the modules that govern interest in others as social entities and social relationships. And those are not characteristic of ADHD children. So we could say that both disorders are highly genetic. Here we see about 2/3 to 3/4 of all cases of ADHD being inherited or genetically influenced, and the balance are usually the result of pregnancy and to some extent birth complications, with a very small percentage developing after birth. In ASD, the genetic contribution is as great or even greater, and we see that just as in ADHD, some cases can arise as a result of new mutations occurring in the parent's eggs and sperm that are not otherwise characteristic of the parent's DNA and other cells. These de novo mutations are thought to cause up to 25% of ASD in children. That is about 10% in terms of how much ADHD such de novo mutations are likely contributing to. And while these are somewhat speculative figures I'm giving you because we need to do much more research, one of the exciting areas in both disorders is the role that these de novo or new mutations may be causing in creating these disorders and possibly in increasing their prevalence over the last decade or two. Now, the kinds of treatment we use for both disorders can be seen here, where you see that each disorder often involves a treatment package of 5 things. Educating families about the nature of the disorder, which leads to understanding them as neurodevelopmental, which hopefully leads to reframing the child's disorder as biological, and that should lead to compassion and greater forgiveness of the child's difficulties and acceptance of them as a neurodevelopmentally disabled individual. Following that, there will be the need for behavior modification, often delivered far, far more intensively to ASD children through applied behavior analysis, which we do not use with ADHD children, where behavior modification is principally the training of parents in behavior management methods that are much milder, involve contingency management, and are done by the parents and not necessarily by an ABA therapist. And the same is done in school to help with behavior management there. Both disorders are going to require accommodations in various contexts so that the individual is less impaired. But the nature of those accommodations is going to involve dealing with the executive deficits that ADHD produces, which, as I've pointed out, can be quite different than the accommodations one would provide to a child or teen with ASD. Most children with ADHD are going to be treated with medication, up to 80% at some time in childhood or adolescence. There are no medications that directly treat the symptoms of ASD. Where medication is used, it is being used for a comorbid disorder, such as ADHD or anxiety disorders, or to some extent, even aggression, where we might find that the atypical antipsychotics might be used, or some of the antihypertensive drugs, such as the alpha-2 agonists like guanfacine. So the management of these disorders, while somewhat similar at the global level of components in a treatment package, at the very specific level of each package, they're often quite different. There have been a number of advances in medication and ADHD. I won't dwell on them here other than to show you that. So far, there have been very little advances, if any, in medications for ASD, although there is some promise being shown in studies in Israel and others beginning here that the CBD component of the marijuana molecule might be useful in helping with some aspects of ASD, such as with anxiety and emotion regulation. But that is not necessarily going to be specific to ASD, as it's quite likely it would achieve similar gains in ADHD. As I've said, the nature of the psychosocial treatments used for ADHD are often milder, involved contingency managements used by parents and teachers, may involve incorporating routine physical exercise, working on improving sleep if that's a problem in ADHD, and doing some cognitive behavior therapy targeting executive function deficits by late adolescence into adulthood. That, of course, would not be something that we would necessarily be doing for most people growing up with ASD. There's a number of experimental treatments for ADHD that you see here. I'm not going to dwell on them because at the moment, while they have promising evidence, they are not yet ready for prime time, in my opinion, though parent friendship coaching is nearing that level of evidence. But for the rest of these, though some promising evidence exists, we need much more research before we would recommend them for use with people with ADHD. And in no instance would we recommend these as treatments for ASD. Here are the unproven remedies for ADHD. I'll just list them. And the same would be true for ASD as well, perhaps with one exception, where some social skills training with ASD children might be beneficial. That has not been shown to be the case for ADHD, where social skills training has been shown to be an utter failure, with the exception of the parental friendship coaching model that I just mentioned. So to conclude, ADHD is a primary disorder of executive functioning and self-regulation. ASD is not. It's a primary disorder of social communication, social interaction, and often coupled with restrictive and repetitive interests. Where there are executive function deficits, they are secondary to these primary problems and not the primary problem in their own right. Though distinct, these disorders can certainly coexist with each other. But don't forget, some of the overlap of ASD with ADHD might be driven by the discovery of the new attention disorder, SCT, or what I have called concentration deficit disorder, though that's not necessarily the new name that it will be given by the end of this year. There have been many advances in the treatment of ADHD, particularly for medications and delivery systems, which have not been found for ASD, at least not yet. And we have made some advances in the psychosocial treatments for ADHD, indeed developing some new ones, such as parental friendship coaching and its classroom equivalent, the Mosaic program for social skills, as well as developing cognitive behavior therapy for executive function deficits in adult ADHD, not to mention adult ADHD coaching. None of those would be appropriate for ASD children and their disorder. ADHD is among the most treatable disorders in psychiatry, responding very well to a use of these combinations of therapies. And while ASD is certainly treatable, particularly by intensive applied behavior analysis, there hasn't been an awful lot of developments in psychosocial treatments for ASD since that time, perhaps with the exception of the Denver Early Start parenting program and its modification for use with teachers. But even there, the response to that intervention, while helpful and improves ASD, would not be said to produce anywhere near the degree of improvement we see from psychosocial treatments in ADHD. Thank you for joining me for this lecture. I hope that you have found it to be informative. Be well.